Hello and welcome to part 2 of our webinar series on post-traumatic stress disorder, evidence-based treatment, and the DSM-5. I'm Richard Nongard.
I'm David Park.
That's correct. And we're almost ready to begin. If you would, take a minute and sign in over in the chat box here, say who you are and where you're from. That would be awesome. If you're not watching this as a real-time event and you're watching this in our 24/7 video on demand center, everybody who signs up for any of our webinars always gets access to the archives and can earn CEUs on their own time. You can ask any questions by visiting our forum at changeworkforum.com. We have many other webinars coming up. Please check out the schedule and find out more about our monthly courses on professional ethics. Dave Park and I are offering a webinar series titled Taking a Life, Counseling Those Who Have Killed Other People. And there are many other webinars offered at fastceus.com. Thanks for participating. We'll get ready to get started here in just 1 minute. If you want to do the clapper thing. Awesome. Hello, I'm Richard Nongard, and this is Dave Park, and welcome to part 2 of our webinar series on post-traumatic stress disorder, the DSM-5, and evidence-based treatment protocols. Last part 1 of our webinar series, we spent most of the time providing a foundation of understanding about some of the changes in the diagnostic criteria related to the DSM-5 and introducing some strategies that can be useful for mitigating the distress that the client who is seeing us for treatment of post-traumatic stress disorder may be experiencing. In the time that we have today, we're going to go into much greater detail about specific strategies and techniques that you can utilize to assist your clients. And in following up from last week again, it is not a matter of in session 1, this is what you do, in session 2, this is what you do, in session 3, this is what you do. Each client has their own unique needs. And as we spent time last week talking about assessment related to suicidal ideation, assessment related to the manifestation of various symptoms, you can see that there really is a broad range of difficulties that clients may be experiencing. And so today we're going to focus on those evidence-based treatment protocols that are identified in Edna Foa's work, as well as the work of other writers in the area of post-traumatic stress disorder. But more importantly, instead of simply talking about those things, we're actually going to demonstrate those. We'll perhaps role play a little bit back and forth, but also encourage you to go through some of those same processes that we go through. And we'll be talking about cognitive behavioral therapy, about the use of psychopharmacology, about EMDR, about hypnotherapy, about EFT, and about acceptance and commitment therapy. Now, when I talk to therapists about intervention strategies and ideas, of all of the evidence-based strategies that I just mentioned, the one that they are always least familiar with seems to be EFT, or the emotional freedom technique. And Dave does a lot of training in this area with other therapists, teaching them the basic skills and patterns of EFT, and he's going to be demonstrating that for us here. You can role play with me as a client, and you can even have those participating in the webinar at home and go through the processes. But I think it's really important that we really begin to think outside of the box with some of the clients that are really extremely difficult and have tremendous problems. Again, the purpose of this workshop is to not go into all the research, but actually demonstrate the methods. You can simply go to scholar.google.com and you can type in emotional freedom technique, or EFT and anxiety, or EFT and symptom relief, or EFT and post-traumatic stress disorder, and you'll find really a tremendous amount of evidence as to its efficacy with a really wide range of patient populations. So Dave, I'm going to turn it over to you and let you really expand on the idea of EFT, how it's utilized, who it's appropriate for, and how it could be incorporated with some clients into the therapeutic process.
Okay, well, there is a handout that you can download. And
yeah, one, you've already downloaded the handouts. When you signed up for the course, you actually got a PDF that directed you to this page, and we've attached a handout there. If for some reason you lost it, can't find it, you can always email our office. We'll get you another one. But I posted it in the files section of changeworkforum.com. So you can just go to changeworkforum.com, click on the files tab, and you'll find the handout for this course.
Right. So the emotional freedom technique was created by Gary Craig in 1993, and he based it off of a treatment system, or a energy psychology system that was already out there that's called thought field therapy. Now, thought field therapy was a system of tapping on different energy meridians, and it was very complex. You know, it's based off of acupressure and the different meridian points. Now, the reason that EFT may work, because Gary Craig said, well, you know, I found that these certain points are the ones that seem to always work. We don't need to create these formulas based on the presenting symptoms that the client's given us. So the reason why EFT may work, because we know that it does work. It may be the energy meridians. There may be something to Chinese medicine.
And we're talking about, we're really talking about Chinese medicine here. I went to a foot reflexology place in the mall the other day, and it felt great. I'd been walking all day long, and the mall was in Las Vegas. They had a foot reflexology thing. So I went and did that, and they have a chart that shows if you press this, it affects this, and this, and this,
right.
this, and affects this. And so one of the reasons why EFT may work is essentially the same reason, because of acupressure on certain points
right.
that come from Chinese medicine.
Correct. Now, it could be that it's simply ritual and rapport. Okay. That we're giving them a ritual in which to almost have an excuse to resolve their symptoms. It could be that this is a hypnotic process, and so it may achieve its ends through hypnosis. The other thing is that there's research that indicates that any sensory stimulation above the torso applied to the upper body can disrupt the emotional elements of a memory. Okay? And there's actually some not conclusive, but there's some very interesting evidence. A gentleman, Dr. Melvin Harper, in Traumatology, December 15th of 2011, posted an article, or a paper, that said that animal and human studies have shown that the emotional aspects of fear memories mediated in the lateral nucleus of the amygdala can be extinguished by the application of low-frequency tetanic stimulation, the contraction of muscles, or by repetitive sensory stimulation. Now, when you think of EMDR...
I was going to say, sounds a lot like EMDR and the repetitive, either visual stimulation or...
right.
Which, by the way, we see in hypnosis, too, with the old pocket watch.
Right.
The eye fixation, or even the bilateral sound waves
right.
that can be used for repetitive stimulation.
Right, and he said such as tapping the cheek. So the thing is, that what I found interesting when I read this study was... If you remember, I always think back to the movie Airplane when the woman was in hysterics and the long line of people. If you remember, what was the old treatment for somebody in hysteria?
Slap them.
Right, which is kind of interesting when you think that sensory input will mediate.
That was my favorite part of that movie,
right.
By the way. She's hysterical and everyone comes up and smacks her.
So I'm not going to read the entire paper, but I do want to read the second part of it. And it says... Nearly all sensory inputs applied to the upper body result in wave power sufficiently large to quench fear memory networks, regardless of input location and type, and whether the sensory input is applied unilaterally or bilaterally.
So it's interesting that his theory is not that energy meridians cause the change. That may have been the ancient explanation for why this worked, but modern journals aren't. You know, it's interesting how sometimes we get the technique that produces change correct, even if our belief as to why that change occurs is not correct.
Right, and sometimes when we notice something, right, we relate it to whatever we have, the cultural and historical awareness that we have at the time.
You know, I tend to think that most therapy is actually ritual.
Right.
That when clients come into my office, I've never met them before, but the purpose of therapy is often to ratify a change which has already taken place. They were in enough pain to make the call, they made the appointment, they took a day off, they came over to my office, they showed up. My job really is not to create change, because by doing that process, they've already committed to a path of change.
Right.
It's my job to simply ratify that change and teach them how to continue in that process of change. Now, a lot of therapists in our ritual were taught to talk to people. We do a talk therapy ritual. And so when we teach a therapist to train a client in a skill like EFT, where it's very kinesthetic, they're tapping, they're touching, they're becoming involved in the process, I think a lot of therapists say, well, this is too different for me. This is a ritual I'm not familiar with.
Right. Well, essentially, when you think of it, first off, we know that rapport can be the number one indicator of success in any type of modality, right? The second thing is you know, there's a lot of talk these days about empowerment. Empowerment. It's a very catchy term.
Empower the PTSD clients.
Right. So what a lot of people who use the word empowerment don't do, though, is they don't define what empowerment is. And the way I define empowerment is to give choice, to give options. So when we empower a client, we're basically giving them a choice and options where they no longer knew they had any. And I think this is whether you're working with PTSD or you're a marriage family therapist working with a couple. To empower that couple is to give them new choices that they never knew they had and how they relate to each other.
And sometimes when I introduce an idea like this, or mindfulness meditation, or self-hypnosis training, I'll simply say to my clients, sometimes by acknowledging the absurdity of the experience, I can build a level of rapport with the client. And I'll even say to a client, I'll say, I know you've been to therapy before and you've attempted several solutions to resolve this pain. It's really kind of interesting. There's some research to indicate that by taking an approach that doesn't just look at intellectually the problems, but actually involves you physically in a process, can help you make change. And so, although it looks kind of silly, I'll acknowledge that aspect to my clients. The research indicates the value in actually learning a process of tapping or whatever it is, and so if you'd like to learn that strategy that a lot of other people have found helpful, I'd be more than happy to teach it to you.
Right.
And then they say, wow, it's not my idea. Here, I'm going to show you this weird looking ritual. It becomes their choice to learn something useful to them.
Right.
And that's just a great strategy for introducing these
something
ideas.
that they can do on their own when they're not in the office. They're not dependent upon, and it's sort of CBT does the same thing, right? It shows us thought distortion, cognitive distortions, and gives us the tools that we need in order to counter those.
And I'm a firm believer in homework. Every client who comes to see me for therapy, no matter what the presenting problem is, every one of them gets homework assignments. The reason why is they live in a world where there's a lot of things vying for their attention, and they'll forget to focus on the tasks of change between now and my next session, which may be a week later or 10 days later, depending on the type of environment, maybe even a month later. And so by giving homework assignments, things that they can do, if it's not the energy meridians, it's the constant awareness of the process of change.
Right, and when we look at PTSD, what is it? It's a habit of having these intrusive thoughts. Because if you ask a combat veteran or a emergency room doctor or a paramedic or somebody else about a particularly bad event, they may talk about it, they may revivify it a little bit, they may get emotional about it, but the difference is they don't do it frequently. So it's not a habit for them to do it. So if we think of the cognitive errors, if we think of all these other things as habits, then the thing that possibly that people who suffer from PTSD, have that another person going through the exact same thing is a habit.
So one of the other reasons why EFT may be effective is because it's a pattern interrupt.
It is a pattern
interrupt. It breaks their daily pattern of depression, intrusive recollection, paranoia, dissociation with something very specific and very present, similar to what mindfulness does.
Correct. Absolutely. So I want to talk a little bit about the research and the efficacy of EFT. And again, as Richard mentioned, you can go to scholar.google.com and look for emotional freedom technique or EFT with PTSD or with any type of challenge that a client may present. So I'm just going to talk a couple of things, and I'm not going to go over these. But in one of the studies done by at Stanford,
you're not going to go over these in great detail.
Say again?
You're not going to go over these in great detail.
What did I say?
You said you're not going to go over these.
Oh, I'm not going to go over them in great detail. Exactly.
But to highlight the efficacy.
Yes, to highlight the efficacy.
Is there. This isn't one of those areas where we say, I wonder if this works, let's try it. We have the studies that demonstrate that there isn't anything that fixes all clients all the time. If we did, we would be pharmacists.
And everybody would be out of business.
Right, everyone would be out of business, right. But there are things that can be useful with some clients some of the time. And the research actually shows that EFT is one of those tools.
So from Staffordshire University, they basically they said that participants were a convenience sample of 25 third-year foundation degree level complementary therapy students undertaking a research module. Okay? And so what they did is they determined kind of a SUDS and a HADS, a hospital anxiety and depression scale, and the subjective unit of distress. And once they determined that, they did the EFT, and then the end was there was a significant reduction in the subjective units of distress, and the HAD anxiety subscale. Right. And then I have another one on here from the Journal of Nervous and Mental Disease from June of 2011.
Oh, this is in the handout.
Right, it is in the handout, and it compares EMDR to EFT, and it finds that both of them are effective in the treatment of the in the SUDS, the post-traumatic stress disorder. Yeah, total of 46 participants that were split between the EMDR and the EFT. They were assessed at baseline and then reassessed at 8 weeks. And then a 3-month follow-up. And then basically, overall, the results indicated that both interventions produced significant therapeutic gains.
Yeah, and that's really a great line to look at when you're reading an abstract or a journal article. Produced significant gains, as opposed to what I see in many journal articles, which are statistically insignificant changes between the control group and the other groups.
Right.
And so, we see that in a variety of different settings, with a variety of different conditions, there's demonstrated efficacy. And again, I wish that everything worked for everybody always. But when I have a new client, I've never worked with them before, and I'm looking for a pathway to break what may have been a 2, 3, 4, 5, or 10-year or longer period of difficulty, I got to ask myself, what can I actually do with this client during my session that would be useful? Teaching them EFT, basic processes would be useful. So how do you teach basic EFT processes?
So here's the basic EFT process, and I'll break it down for you. So the first thing we ask is what is the problem? Okay? And, if somebody comes in with PTSD isn't the problem. Okay. The symptoms, the things that lead them to believe or lead you to diagnose PTSD, those are the problems. Not being able to sleep.
The problem is I can't sleep. The problem is I have intrusive thoughts of a bull goring my neighbor. My wife is going to leave me because I am paranoid and asking her to do things that are out of the ordinary in response to my own fears.
Right, exactly. So once we find out what the problem is, and look, they may have a list of problems, and we're going to deal with each one of these symptoms on its own,
Right.
typically. All right. So we're going to rate the level of subjective units of distress. We're going to rate the SUDS from 0 to 10, with 0 being not at all and 10 being the highest. We're going to do that at the moment they're feeling it.
We're going to do it or they're going to do it?
Well, we're going to ask them to rate it.
So this is basically a self-report.
Right.
Okay. Which I love. I love self-reports because what's most important is what my clients' experience is. You know, I do a lot of pain control work, and the clients who I work with, they've been to zillions of doctors and may even had surgeries, and the doctors basically say, it's all in your head. Go see a therapist.
Right.
They show up in my office, and they, you know, they really feel crazy. They say, you know, this really is pain, but they can't find a cause. I love the nursing definition of pain. The nursing definition of pain is whatever the patient says is pain is pain.
Right.
And so subjective measures really is useful information.
Right. And when we collect that, if at the time their level is, for instance, a 2, we actually want them to revivify it a little bit because we want to increase that anxiety level because we want something that we can test. You know, and from neuro-linguistic programming, we have the model of TOTE, T-O-T-E, which is test, operate, test, exit. Now that could be test, operate, test, operate, test, operate, test, exit, whatever. But the idea is we want them to be in an elevated state to see if we can reduce it through this means. One, that lets us know that this is effective for them. 2, it lets them know that it's effective for them. If they feel it's effective while they're in front of you, they're more likely to go home and practice it and, you know, give them the assignment of doing it once a day or twice a day or when the symptom presents itself. So then we get the client to describe the situation, the feeling, the pain in the fullest detail they can, while using all the sensory input, while using all the metaphors and everything else like that. We want to have a complete understanding of how they're experiencing this. And if you remember in the last session, when Richard told me about the picture he saw, I really want to know, is it close, is it far, is it bright, is it dim, is it black and white, is it in color, you know, all these different things. So the first thing we're going to do, and there is in the handout, there is a chart that comes with this, all right? So you can follow along with that if you can't see very well.
But would it be helpful if I move this table, Dave?
No, this is fine.
Okay,
actually. So we're going to rub the sore spot, and the sore spot is the area that's just below the collarbone. It's sort of a divot above the pectoral muscle, right? And the reason it's sore typically is because of lymphatic drainage. So we're going to rub that, and we're going to repeat the affirmation. And this is the affirmation that we give. Even though I blank, whatever even though I feel this pain,
even though I see repetitive pictures,
even though I see repetitive
even though
pictures,
I don't sleep at night,
yeah, even though I'm a horrible person, even though I killed those people, whatever is coming up, I deeply and completely accept myself. And as they rub this spot, we're gonna have them repeat that 3 times. Okay. So
even though I can't sleep at night,
I deeply and completely accept myself.
Now this reminds me a lot of Stuart Smalley.
Yeah.
The affirmation guy from Saturday Night Live. I'm good enough, I'm smart enough, and doggone it, people like me. You know, it was interesting when that parody of therapy and self-help came out, a lot of people got a pretty good chuckle from it. But I thought as a therapist, you know, that's really a great affirmation. I'm good enough, I'm smart enough, and doggone it, people like me. And ever since whatever that was, the early 80s, you know, I've been actually teaching clients, hey, you know, use that affirmation from Stuart Smalley. I'm good enough, I'm smart enough, and doggone it, people like me. And they get a chuckle out of it. But affirmations work for really 2 reasons. I think that they're really powerful. One, it literally, when I verbalize an affirmation, replaces the constant self-defeating mantras that subconsciously we are repeating to ourselves all day long. And 2, it challenges my cognitive errors. I might believe the part that even though I can't sleep at night, or even though I keep seeing a picture of the bull goring me, or even though, everyone thinks I'm crazy, and even though my wife is going to leave me, I deeply, completely accept myself. I might not believe that part when I'm saying the affirmation. But when I say the affirmation, especially 3 times, then it forces me to question, I wonder if that's true. I wonder if I could, and this is all a subconscious process, I wonder if I could love myself and accept myself deeply. And if I have to create, I wonder if I have to visualize and experience myself loving myself and caring for myself in order to wonder if I can do that, which allows me to actually create that state of loving and caring about myself. And so it really becomes affirmation, an experiential process of self-confrontation in cognitive behavioral therapy. It's no different than confrontation in CBT, but instead of sitting across the room and ending up in a power struggle where I confront and self-confront my client, get him in the now, Fritz Perls, break him through to the other side in, a first step group and a 12-step program. My client is challenging themselves.
Right.
And so I love affirmations.
Yeah.
Even if they sound silly.
And here's the thing, with these, we align with the client. And this is actually a great tool to help increase rapport. Because, one of our processes through questioning whether, in strategic intervention, in Socratic dialogue or meta-modeling somebody in neurolinguistic programming or whatever it may be, would be, how do you know, right? So, everything is horrible, my wife is going to leave me. Well, how do you know your wife's going to leave you, right? Is it possible she's not? But in this, we're not denying that.
Right.
If they say my father didn't love me, we're not trying to reframe that. We're not challenging a cognitive error.
We don't enter into a conflictual or adversarial relationship with the client. We simply take them as they present themselves.
Yeah. All right, your father didn't love you. Great. All right, even though my father didn't love me, I deeply and completely accept myself. Even though my father didn't love me, I deeply and completely accept myself. And we're just going to rub this just like this. Alternately, there's a point called the karate chop point, and it's the reason they call it that is it's the meaty part of the outside of the palm or the inside of the palm, where you would, if you were a karate student, where Austin Powers may judo chop somebody. But alternate, you can tap that, and say, even though, I have this pain, even though I can't sleep at night, I deeply and completely accept myself. Even though I can't sleep at night, I deeply and completely accept myself. Even though I can't sleep at night, I deeply and completely accept myself. And one of the things I always do is I always tap along with clients. So,
and that's another way of being in rapport with them.
Absolutely.
Modeling for them. If you don't do that, I might become self-conscious.
Right.
That I'm silly.
Yeah.
But if we're silly together,
right.
Now this is normal.
Right.
It's now normal to do this.
Right. So, and it's interesting because when people self-soothe, it kind of is normal, right? Because people a lot of times when they self-soothe, they'll do the things that we talk about, the physical or sensory input above the torso, right? That's sort of self-soothing.
My daughter took a video of me putting my grandson to bed the other day. And it was really interesting. I'm there talking to him, and he's 2.5, and he kept doing this. Right? He was self-soothing.
Right.
And of course he would suck on his binky. Right? And I noticed that in the video, then he would put his foot up in the air and put his foot down. And that's all about self-soothing. That's actually a developmental task of the 2.5-year-old to learn to put themselves to sleep. Because if they never learn that, then they have sleeping disorders when they're an adult.
Right.
And self-soothing not only helps a kid go to sleep, but helps a person in a stressful situation manage their anxiety.
Well, and there's so many modalities out now that are like EFT but different. You have havening, which I think rubs the arms and the face. Right. Somatic experiencing, which is also, and a lot of these address the whole body-mind issue of trauma. The idea that trauma is stored in the peptides and not in our normal memory channels, and so there are a lot of different modalities. But all this kind of goes back to this one study, I think, that shows it's the sensory input. But even with that, because I know that EFT is effective, even if I don't know for sure that it is energy meridians or whatever it may be, I use the EFT recipe anyway.
Right.
So now we're going to tap each point in the sequence 6 to 8 times. And that 6 to 8 times is simply going to be the number of times that you tap as you're repeating the affirmation 3 times. It should be natural. You probably won't even need to count it. And so there are 7 different points, and we're going to go over each one of those. So the first one is called the eyebrow point.
It doesn't matter if you tap with 2 fingers or 3?
It doesn't matter. I normally tap with 2 fingers, and I have the client tap with 2 fingers. And it's what's natural for me now. It's my ritual. So the eyebrow point is right on the bridge, right on the ridge of the eyebrow. It's right basically on the top of the orbit, right? And then it's right where the eyebrow ends. So I'm going to tap that and I'm going to repeat the affirmation. And if while you're watching this, if there's something, you have some negative self-talk or you have some challenges.
In fact, let's go through this. And you're participating in this webinar, you may as well do 2 things. Get CEUs while you improve your mental outlook. So you can think of an issue or a problem that you're wrestling with right now. Maybe it's simply procrastination on your CEU hours. Maybe it's anxiety about getting things done on time. Maybe it's stress in another area. Maybe even it is a personal trauma that you've recently been wrestling with that you found intrusively is impacting your life in certain areas. And you can actually go through this process with Dave here, addressing your own issue. I find that when we do what we ask our clients to do, it actually makes us a better therapist.
So we're going to go ahead and start, and you said procrastinate on CEU hours, so I'll just use that as an example. And we'll start with, even though I procrastinate, I deeply and completely accept myself. All right? So it's this point. Now the second point is outside, and it's called the side of the eye. And it's on the orbit, again, so it's on the opposite end of the eyebrow. Now, you'll see a lot of people tapping their temple. That's actually not the point. It's on the orbital of the eye. It's on the ridge.
An EFT practitioner who believed this worked because of the energy meridians would find this useful. The last journal article you read evidence that any bilateral stimulation in the upper part of the body produces the same result.
Correct.
Even if you miss the point.
Even if you miss the point.
I tend to go with the ritual is the change rather than the Chinese medicine is the answer.
And I agree with that wholeheartedly. And again, the only reason I'm showing these points specifically and where they are specifically is in case your client goes home and gets on YouTube and looks at it and says, well, that's a different point than I'm tapping. Right. Or whatever else, and it creates a little bit of dissonance in them, right. And it affects their belief. Right. Well, my therapist.
Because we act on whatever we believe. If I believe I was taught by my therapist correctly, I will act in a way that increases my success. If I believe my therapist taught me incorrectly, I will believe that this isn't going to work for me, and I might even find myself worse off.
Right. Or I'm confused now, and I don't know, and I'm just even more confused than I was. So it's on the orbital, and again, even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. And the next point is the under the eye point, and again, still along the orbital on the ridge, underneath the eye, 3 times. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. And then under the nose, and where that is just the midpoint between the lip and the nose. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself.
So it works even if you have a mustache.
It does.
Okay.
It does. Next point is the chin point, so it's between the lip and the chin, kind of in the divot. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Now, with the PTSD client, you might be dealing with, even though I have these images, I deeply and completely accept myself. Even though I have these images, I deeply and completely accept myself. Even though the accident was my fault, I deeply and completely. Right. So whatever belief they're giving you, it can be around a cognitive process, it can be around visions, it can be around a physical sensation, it can be around a belief,
Any of those things that the DSM-5 pointed out as stressors in the PTSD client's experience.
Exactly. So the next point is the collarbone point, and what that is it's right where the collarbone meets with the breastbone. So it's the point that's sort of the most prominent point, and there should be a nice kind of resounding thud when people tap that. And then again, even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Okay? The next point is under the arm. And it's, for men, it'll be sort of nipple line, right kind of medial on underneath the armpit. For women, typically it's along the bra line, is where they say. And then you just tap that 3 times, or tap that as you repeat your mantra 3 times, your affirmation. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Okay? Now, we'll go to the hands. Some people include the hands, some people don't. I'm going to go ahead and teach it to you simply because you'll have the entire recipe. But if you use this and as you experiment,
It doesn't matter if you go with one hand on one side or 2 hands on both sides?
It doesn't matter.
Okay.
It doesn't matter. And you may find, for whatever reason, on certain points, people get a little bit emotional charge out of them. So you may stay on that point. And you can play with it. So somebody may say, I just can't sleep at night. I see these really bad images when I close my eyes to lay down. I can't get comfortable and I toss and turn. So you could do I can't sleep at night, and then you could go back over it with even though I toss and turn at night, and you can go back over it even though I see these vivid. You can collect, one of the reasons we collected all of the data, the sensory data and behavioral data in the very beginning, is we can use every single one of those. And
Right.
And we can go through this several times using all the different elements of it. So if I were like trying to give up...
So we're doing let's call it a 10 or 12 minute process here. The client, I may take 30 or 40 minutes.
It could.
I may take even the majority of a session to go through this with them, dealing with multiple issues and allowing them time to focus on
Yeah,
a
it
specific
could.
point.
If they were saying that, like, I eat too many, I eat 5 Snickers a day.
Right.
Well, what do you like about Snickers? Oh, I mean, it's just so
Crunchy.
or sugary or this or that, and it feels so good when it's melting in my mouth. Even though it feels so good when it's melting in my mouth, I mean, you can go through the whole gamut. So really understand your client's model of their experience with this, their subjective experience, and then you can tap on all those. So then we're going to go on the top of the fingers, okay? And it's going to be above the first knuckle, so near the fingertip. And when I say the top of each finger, what I mean is if you were to hold your hand out with your thumb up, that's the top, okay? So this would be the top. So first we're going to tap on the top of the thumb. And we're going to repeat the mantra, even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Next finger, even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. The middle finger, even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. We're going to skip the ring finger and go straight to the pinky. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. So that's the whole thing. Now, there's also and then we can do the karate chop. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Even though I procrastinate, I deeply and completely accept myself. Now there's also a process when you're done with that called the 9 gamut. A lot of EFT practitioners have actually dropped the 9 gamut from their recipe, from the EFT recipe. I'm going to go ahead and show it to you anyway. But just know that you can probably go through this process a couple times and test and see if you think that the 9 gamut is needed.
And by the way, I'm going to give you, the viewer, an assignment. You have the notes, you have the instruction that Dave has just gone through. Later on today, when the webinar is over, take 10 minutes and go through this process yourself, dealing with your own issue. Practice this several times over the next couple of days before you ever address this with a client, and test it yourself. And find out, is this a useful tool for you? And if it's a useful tool for you, with passion, you'll be able to pass that useful tool on to others.
Right. Right. So the 9-gamut starts. The reason we skip the ring finger is the 9-gamut starts by tapping the area between the pinky and the ring finger, the area in about a ½ inch up from the knuckles. So we're going to tap that, and as we're tapping it, we're going to close our eyes. We're going to open our eyes. We're going to look down hard right without moving the head. Come back to center. Look down hard left. And again, you may see some EMDR similarities here, right? Look down hard left without moving your head. Then you're going to roll your eyes in a clockwise direction, roll your eyes in a counterclockwise direction. Then you're going to hum 2 seconds of any song, whether it's "Mary Had a Little Lamb" or "Row, Row, Row Your Boat," and then count quickly from 1 to 5, 1, 2, 3, 4, 5, and then hum again, and that's it. And again, that's
more. Even though that's simple, I think I probably would have to practice that a couple times to get it committed to memory. So if I were working with a client, I would want to practice them at the beginning, the middle, and the end of my session, and then give them maybe even a recording of this, or send them to lots of YouTube videos teaching.
Lots of YouTube videos teaching.
And so they could actually practice it, so it became a habit they can get engaged in. And one of the other aspects of this is, especially once you start humming "Row, Row, Row Your Boat," it's simply a distraction technique.
Yeah.
It's about thinking about something else. You see, if I spend all of my time thinking about my trauma, and I don't practice thinking about something else, it will become normal for me to be traumatized. It won't be normal for me to think about something else.
Right. It's a great pattern.
One of my favorite writers, Thich Nhat Hanh, talks about being grateful for his non-toothache. What do you mean? Grateful for a non-toothache? He says, my tooth does not hurt today. I am grateful for my non-toothache. The point is, we often are only aware of our teeth when we have a toothache.
Right.
Yesterday I noticed that I chopped my food too hard, talked too much, and probably ate too much gum. That usually does it for me. And I noticed last night my toothache.
Right.
Okay. And that's what probably reminded me of Thich Nhat Hanh, because it made me aware that, wow, I am now aware of my toothache, but all day long when my teeth were fine, I wasn't aware of my non-toothache.
Right.
But I had a non-toothache all day long.
Well, it's like our feet. You really only notice your feet when you start to develop a blister.
Right.
You walk all day long, you don't at all think about your feet typically, unless your shoes are too tight.
Right.
Or you develop a blister.
Right.
And suddenly, wow, I notice every single step I take.
Right.
So now that we've done the entire process, we're going to check once again their subjective units of distress and see if there's been any change. And again, you can actually speed up this process after doing it the first time. So I could say this procrastination, this procrastination, this procrastination, this procrastination, this procrastination, this procrastination, this procrastination. Just that quickly, you can take them through it over and over again. You can focus on a certain point, this procrastination, this procrastination. You can focus on a different point. So, and we're going to do that until we get some resolution. We don't need to get to 0.
Right. So if they come in and they're stressed at a level 9, they may be willing to try this without me having to convince them, because I'll do anything, no matter how silly it is. And if I can get them down to a 7 or a 6.
If I can get them to a 6, I'll do it again and see if I don't move from a 6 is great.
Right.
And one of the things that we really don't celebrate enough, whether it's in therapy or in intervention or whatever else, is celebrating wins.
Right.
Right? We want full resolution of a symptom. But if we can get them from a 9 to a 6, that's cause to celebrate.
That is the difference with some clients, a level 9, between going to jail because they exercise poor impulse control and desperate coping strategies, and 6, not going to jail. Because although the coping strategy they may employ here may not be the most helpful thing in the world, it's not the one they employ when they're at a 9.
Right. The other thing we have to realize is that if we have a client who has been living, for instance, with post-traumatic stress for a year or 2 or 10, they may not be quite ready to let all of it go yet, because they have no idea what their life will look like afterwards.
Sure.
They have become a source of certainty for them. And there may be serious secondary gain in having it. If they're a veteran, they're getting disability.
Right.
They're getting money, they're getting education.
Right.
Now, I'm not saying that this is why they're doing
They're not feigning
Right.
PTSD so they can get benefits, but once they get the benefits, to get better means it's almost a catch-22. You're no longer eligible for the benefits that you couldn't afford yourself.
Right.
And so they're, from a financial perspective, that's true. And it's also true even in a relationship perspective.
Absolutely.
If I'm the disabled PTS survivor, maybe my wife has been caring enough about me and the family to take the responsibility of working and all these sorts of things. And now if I get well, that means that I'm going to have to give up what I really enjoy, building matchbook ships in the garage, because
Right.
I have to go to work 8 hours a day.
Right.
And it's not that I really mind working 8 hours a day, Walmart, as a Walmart greeter or whatever it is I might do, but I really like building ships out of matchbox.
Well, and if I haven't been to work for 3 years, it's
scary.
kind of frightening
Yeah,
to go back to that,
sure.
right?
Especially if I'm in a field like med tech, paramedic, a police officer, where technology may have changed, or graphic design. I knew a graphic designer who had been disabled because of their mental illness for a period of time, almost 7 to 8 years, and now was actually doing well enough to consider going back into the workforce, but found that the change in technology in the graphic arts business had changed so much that became an overwhelming frustration and fear of theirs.
Right. And so I think when dealing with this, we have to look at resiliency and transition issues, right? Just like in the military, a soldier coming home, you have to look at the transition issues that they may be facing too, because it may not be beneficial for them to give up post-traumatic stress in their model of the world, So the next method we're going to talk about with EFT and PTSD, which is really what a lot of people are using with PTSD, is the storytelling method. Okay, the storytelling method has to do with when a person has a story that's running over and over and over in their mind. So if a person ran a red light and hit a car, or if a person was in combat and an event happened, you're actually going to have them tell the story. Now, typically, like in hypnosis and things like that, we really don't want to do the regressions. We don't want to revivify the experiences. In this case, though, we are revivifying because we're looking basically for the heads of wheat, and we're going to cut those off as we go. So as they tell their story, their instructions or your instructions to them is going to be, all right, I want you to start telling me the story. And as soon as you start feeling anxious, I want you to let me know. So they may say, okay, we went out on a combat patrol. We were driving down the road, and I saw, an Afghani running off. Okay. And all right, I'm starting to feel a little anxious now because I started to get worried there. Okay. So even though I saw the Afghani running off, even though I saw the Afghani running off, and then what we're going to do, and actually, I skipped a point there. We're going to find the SUDs on each one of those. So when you saw that Afghani running off, as you're thinking about it now,
I was a level 6.
Yeah, or even now, where am I? Right? As you see that Afghani running off in your memory, where's your level? And so we're going to work each one of those issues independently. So all right, so I'm a 6. All right, now I'm a 2. Okay, good. So what happens next? Continue the story. So then we're driving, and I hear a large explosion. I hear a large boom. Okay, and as you hear that large boom, what's your level of anxiety? It's at an 8 right now. Okay, or I saw the Humvee in front of me explode. All right, what's your level of anxiety? It's an 8. So tap. Even though the Humvee in front of me, and you may need to go. What did you think when you saw the Humvee explode? Well, my best friend Bob was, in that Humvee. And I thought of his wife and his family. And so, even though my best friend Bob, even though, he may be dead, even though his wife and his family may lose him, whatever comes up, we're going to tap on that. And we're going to go through the entire story and tap on every single incident in that story that causes distress and anxiety.
Now, let me sort of personalize this for a minute, because this is really a great question, because I know a lot of people are working with veterans, And a lot of people who are working with veterans are not veterans, like myself.
Right.
My grandfather was in the Army. I grew up on base, actually, Fort Sheridan, Illinois, which probably explains why I never joined the Army. My son is in the Army, but I really have no, firsthand knowledge of military experiences. It's certainly not my area of expertise. I got my hair cut at the base and shopped at the PX when I was little, and I've been down to visit my son at a couple of different duty stations over the last year. But that's really the extent of my military knowledge. If I have, and you are a veteran and you were an Army Ranger, if I ask you to go through this process, is this something? I think a lot of people say, soldiers, they don't want to do something this silly. I mean, is this something you would be willing to do in a therapeutic process?
Gary Craig did a lot
Sure.
of his work with veterans at Veterans Administration buildings or in the VA
Right.
system. You could ask that question of, if you were a combat veteran, would you even go see a therapist and
Right.
say you had a challenge? So everybody's going to be different.
At a different level.
The level of rapport that you
Now,
have with
on
that
a personal level, has this process, EFT, been beneficial to you in your own emotional life and experiences?
It certainly has. Now, I cannot say, that I have suffered from PTSD, but for my own personal experiences, yes, it's been very
in other
beneficial.
areas of
Yeah,
life,
in other areas.
stress and anxiety,
Absolutely.
or
In fact, like I said,
motivation.
one of the reasons I love teaching this to people is because I tap with them every time I do it.
Right.
So there's a lot of secondary benefit for me, by tapping with them.
Sure.
Now also, if the veteran does not want to talk to you, if they don't want to tell you the story, if you don't have that level of trust, if they don't believe, you can do this content free.
Right.
You can have them think through the story or what's bothering them in their own
And
mind.
simply say when they feel anxious.
And say when.
Go through in your own mind the part of the story that's distressing to you. See yourself in that situation. You don't have to tell me what it is.
Right.
But when you get to a point where you feel anxious, let me know.
Yeah, let me know. And then you go, okay, I feel anxious now. And you go, even though I feel anxious now, or even though I'm remembering this now, or even though this event happened, or whatever it is that they're doing, they can say, even though I feel anxious right now, I deeply and completely accept myself.
See, now, I think a lot of therapists take it personal when a client won't share the details of their trauma. I think that I'm really sort of an exception among therapists. Most of the time, I want to do things content-free. I don't want to know the details of their trauma because it's really not relevant to my ability to create an intervention to help them. And I want to be able to guide them through this process without me becoming lost in the details of their experience.
Right.
Because what happens when you verbalize this is then I decide what I think is important and project that onto you rather than simply letting you understand what's important.
Right. And a lot of the things, because you're right, a lot of times when we're working with clients, we may get sucked into the content.
Sure.
When really what we kind of need to do most of the time is focus on the structure of their subjective reality and what's happening.
Sure.
Not necessarily what the specifics
details.
of their subjective reality.
Exactly.
So that is essentially EFT, Emotional Freedom
Simple
Technique.
process of EFT that we can actually utilize with the PTSD clients.
Correct.
It's a lot of acronyms. Speaking of acronyms, we're going to spend a moment and talk about acceptance and commitment therapy. Acceptance and commitment therapy is one of my favorite approaches to psychotherapy. Stephen Hayes wrote a book, it's actually a workbook for clients titled Get Out of Your Mind and Into Your Life. Now, I can teach a semester-long class on acceptance and commitment therapy and not have time to cover everything. I want to just touch on a couple of key points. There is another webinar that I offer on effective evidence-based treatment protocols, including acceptance and commitment therapy and solution-focused brief therapy, where I spend a lot of time really sharing some of the ideas and techniques. But Stephen Hayes is a researcher at the University of Nevada who really began his work looking at an application of psychotherapy to social anxiety. And if you remember, in the DSM-4, although not true in the DSM-5, PTSD was under the umbrella of the anxiety disorders, and we see a lot of parallels. And so many of the techniques of acceptance and commitment therapy have been applied to the to those with post-traumatic stress disorder. And I want to share with you one strategy or one technique that I think is really important. And this incorporates ACT therapy, acceptance and commitment therapy, incorporates the ideas of relational frame theory. In other words, we have an adaptive ability, and that is our minds can relate, because we're humans, anything to anything. This is an evolutionary trait that puts us in charge of the planet rather than whales being in charge of the planet or dogs being in charge of the planet. It is our mental capacity for creating relational frames. We're the only animal that does this. Other animals don't do it. By relational frames, what I mean is we have an experience, a thought, a cue, an awareness, and we can relate it to something else. Now, this is great from a problem-solving evolutionary psychology perspective. It's not really great when we have PTSD, because what happens is I hear a noise down the hall, and my relational frame is that must be a robber. Let's say, for example, my trauma was caused by living in a rough neighborhood where there was helicopters and gunfights outside every day, and one day my door was kicked down, and when the building was robbed, and people in the apartment were raped, shot, mutilated, whatever else. I survived this. Now I'm in a safe place in an entirely different scenario, but it's 3, 5, 10, 15 years later, I hear noise down the hall, and I say my relational frame is arbitrary. It's not based on fact, and it is, I'm now unsafe, or that is a robber, which that assumption, it doesn't just make an ass out of you and me. It actually is more severe than that cliche. It causes the emergence of emergency coping strategies, which with some of our clients can actually be a matter of life and death. So let's talk a little bit about how the human mind works and how acceptance and commitment therapy can help break these relational frames. So here's an experiment for you, okay? Grab a piece of paper, a notepad somewhere. If you don't have one, it goes on a computer, open up a notepad, that's fine. And I want you to write down the name of any noun, any object. It can be anything you can think of. Be a car, a bus, a microphone, a table, a chair, doesn't matter. Anything you see in the room or anything you can think of, write down a noun, write down an object.
Can it be a balloon?
It could be a balloon. It could be anything you wanted to. So did you come up with balloon?
I did.
All right, great. So there's balloon. Now think of another object, another something, another noun, okay? So you can think of whatever you want to. You can be in the room or not be in the room. It can just be something you think of. You thought of a balloon. What else did you think of?
Groundhog.
Okay, great. Write that down on a piece of paper. Balloon and groundhog. Here's 3 questions. This is really pretty amazing. The first question is, how is the first noun like the second noun? In other words, Dave, how is a balloon like a groundhog? Think about it for a minute and write down your answer on your piece of paper. Here's the second question. How is the first noun better than the second one? How is the first noun better than the second one? So how's a balloon better than a groundhog?
It doesn't bite.
Just write down your answer. Okay. Now the third question. How is the first noun the parent of the second noun? How is the first noun the parent of the second noun? And this is an exercise from Stephen Hayes' book, Get Out of Your Mind and Into Your Life. You might have to use your brain a little bit, but come up with an answer. Everyone needs to come up with an answer. How is a balloon the parent of the groundhog? Do 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 do. I'll keep my day job and will not become a singer. But you've come up with 3 answers. Dave, how is the first noun, how is a groundhog, or how is a balloon like a groundhog?
Well, I said February because anyway, my birthday's in February, and isn't Groundhog's Day in February?
Something like that.
I could be wrong, but
Okay.
anyway,
Close enough.
relationally, that's how I put them together.
Look, and this is how the mind works. It comes up with these arbitrary connections that really aren't based in reality.
Yeah, I don't
but
even
it's
know if
pretty darn
Groundhog's
creative.
Day is
Right.
in February
But you
or
thought
not.
my birthday is in February. That means balloons, and Groundhog Day is in February, and
So it's February.
So it's groundhogs have balloons too. So
But it came.
so
like,
ultimately,
to
it
my-
all revolves around you.
Yeah.
All right, great. So,
Doesn't it all?
So this is an example of how we've created an arbitrary relational frame. The second question, though, of course, is how is a balloon better than a groundhog?
It doesn't bite.
It doesn't.
And I don't even know if groundhogs bite.
I don't know if they might either. They probably don't, because people are picking them up to look and see if they see their shadows. But I don't want to find out the hard way. Now, here's the difficult one. People tend to have a little more difficulty with it, but they always come up with an answer. How is the first one the parent of the second one? How is a balloon the parent of a groundhog?
A balloon is it's a product of technology,
Okay.
and so I thought that technology rules over nature.
Okay, there you go. Again, it's an arbitrary relational frame. It doesn't matter if your thought makes any sense or not. What's most important is everybody can always answer this question. How is one thing the parent of another thing? But you see, now we're getting into logic. Not everything can always be the parent of everything.
Right.
And yet your mind can create that relational frame.
Right.
What happens to our clients with PTSD is they create these arbitrary relational frames. This means that. And because it means that, I must do this. And now we're into Albert Ellis and the idea of masturbation and our clients who engage in self-defeating behavior because of these rules they set for themselves based on arbitrary relational frames that really don't exist. And so one of the keys that acceptance and commitment therapy offers us, among other things, is using mindfulness, which we talked about in the last part one of this webinar, to simply let our thought be a thought, or let an object be an object without attaching a relational frame to it. So what I would do with my client is simply have them close their eyes for a moment. I tend to like to do things with the eyes closed. And let's take, for example, let's take an example of physical pain. Okay? I'm so tired, my body hurts. I'm just so emotionally drained, my body hurts. Okay? And so I would simply have them close their eyes and note what it feels like where their body hurts. And as they breathe in and breathe out, become aware of that place or that spot where the hurt is. And simply see that hurt as hurt or pain as pain. And when they note a thought that attaches meaning to it or significance or an action, simply return your thought back to the pain, only focusing on that. Breaking the cycle of automatically attaching relational and arbitrary frames. Really back to a center point, whether it's the breath, whether it's hunger. I work with a lot of obese clients. You can go ahead and open your eyes if your eyes are closed. I work with a lot of obese clients. And hunger, they've created I'm hungry, that means I have to hit the drive-through window. But the drive-through window is really bad for you if you're trying to lose weight. It's really bad for you even if you're not trying to lose weight. And so that's an arbitrary relational frame. I'm hungry, I must eat. Guess what? Hunger can simply be hunger without me needing to take action. And mindfulness training, this is what Marshall Linehan does in dialectical behavioral therapy. It's one of the core foundations of DBT, is an effective tool for helping break these relational frames. Another great strategy for working with the PTSD client. Now let's look at hypnotherapy. We've mentioned hypnosis and hypnotherapy and hypnotic processes a few times. In Edna Pfau's book on, it used to be on the desk here, but she's got a whole chapter dedicated to the efficacy of hypnotherapy. Now, let's talk a little bit about hypnosis and hypnotherapy. I think those who do not have a background or training in Ericksonian or other approaches to hypnosis often perceive it as something from Hollywood, something strange or bizarre or something mystical. They've watched way too much Oprah Winfrey. The reality is hypnosis really is a training tool. I did an all-day educational conference for the American Counseling Association back in 2008 at their conference in Hawaii, and I called it Skill Building Hypnosis. I think effective hypnosis actually teaches my clients something that they need to know. And what my clients often need to know is how to take physical control over their bodies. Now, there are a lot of different ways to go about inducing hypnosis or utilizing hypnotherapy. But with my clients, I will typically use breath work and I'll typically use progressive muscle relaxation. And many therapists, even if they don't call themselves a hypnotist, are using hypnotic methods. Methods of visualization, methods of deep breathing, methods of progressive muscle relaxation. But I use those because those in the formal process of hypnosis, I'm actually teaching a self-soothing strategy for managing anxiety, the physical distress that we see come along with post-traumatic stress disorder, and I will often incorporate and utilize autogenic training. Now, a lot of times I'll say autogenic training, and people say, "What's that?" It's interesting. It's a technique that was really developed in 1928. Progressive muscle relaxation, Edmund Jacobson's progressive muscle relaxation, tense and relax, tense and relax. In 1932, a German cardiologist named Schultz, he came up with the idea of autogenic training, and the two really pair together. And I learned autogenic training from the nurses on the psychiatric unit where I first worked when I was actually in graduate school. And it's interesting that in the world of therapy, we don't spend too much time talking about autogenic training as an idea, but the world of nursing certainly has utilized that idea. These are all hypnotic processes, and I use them in a formal process with some of my clients because it's an appropriate teaching and training tool. So I'm going to demonstrate a very brief hypnotic process. We don't have a lot of time in the webinar. I do full-day trainings. In fact, Dave and I do trainings together on clinical hypnosis for mental health professionals. On our website at Facet uses an entire course devoted to a basic training in contextual hypnotherapy. But I utilize, really, with most of my clients, a fairly brief process where I teach them the skills of clinical hypnosis. It is easier for me to actually demonstrate this with you than it is for me to simply teach about it. Sometimes the easiest way to learn is by actually doing something. So I'm going to take the next 3 to 5 minutes and simply guide you through an abbreviated but useful process of hypnotic induction. And so, as you watch this webinar, you can go ahead and close your eyes. You can relax in the chair. And you can take in a breath, breathing in and breathing out. You don't have to speed up or slow down your breath. But with each breath, allow yourself to set aside any tension of yesterday, stress about tomorrow, and focus on this moment. Feel the chair below you, hear my voice from the computer speakers. And as you breathe in and breathe out, with each breath, allow yourself to relax a little more deeply. Never asleep, of course, and you can always hear my voice, but deeply relaxed. Now, the tension of the day is often held in the brow, the muscles of the eyes, the muscles of the cheeks, and you can relax those muscles. You can let those eyelids become relaxed. You may have heard a hypnotist out of Hollywood say, "Your eyes are getting sleepy." Well, it's because when you relax them, those eyelids simply become heavy and relaxed. As you relax in the chair, earning CEUs with the eyes closed, unclench the jaw, let the jaw relaxed. And you can even let that chin drop towards the chest, letting the muscles in the neck and shoulders relax, the muscles in the arms relax. And it's kind of fun to notice how relaxed you can actually let yourself become as you breathe in and breathe out. Notice how relaxed the little tiny muscles of the hands resting on your lap can become. And as the muscles in the hands and palms relax, notice how heavy the hands become, kind of like the eyelids. In fact, you can even say to yourself, "My hands are heavy. My hands are heavy." And let those hands experience heaviness as they relax. Now think of warmth. warmth like that which might come from the sun or from even inside of the body, and pay attention to your hands and say to yourself, my hands are warm and heavy. My hands are warm and heavy. And let those hands become both warm and heavy as they relax. Saying to yourself, my hands are warm and heavy. Notice that feeling of warmth, that feeling of heaviness. In fact, so heavy that if you try to lift your hands, you'll find they're simply so heavy it's more comfortable to let them simply sit on your lap. Trying to lift your hands will find they become heavier and heavier just resting on your lap. And as you breathe in and breathe out, let that relaxation spread through the belly and back, and buttocks and thighs, into the calves and the shins, and even to the little tiny muscles of the toes and feet. Feels good to let them relax too. And as you breathe in and breathe out, note the difference between the tension of the day and the state of relaxation that you have created here and now. This isn't a state that I've given you or that a drug has induced, but simply a state of creative relaxation that you've created yourself by going through a process of progressive muscle relaxation, autogenic training, and simply paying attention to your breath. And notice how wonderful it feels not only to earn CEUs with the eyes closed, but also to simply take a minute during a stressful and busy day to center yourself, learn something new, and feel awesome. And any time over the next day or 2 or 3, you find yourself caught up in the stress of the moment, you can anywhere. Close your eyes for a moment, take in a breath, and bring yourself instantly back to this state that you've created right here and right now. But because this is only a brief demonstration, go ahead and pay attention to the floor below you, the air in the room around you. Take in a breath, get ready to open the eyes. When I count to 3, open the eyes, feel fantastic. 1, 2, 3, opening the eyes. Now, that was a very short and abbreviated process, but it felt pretty awesome, didn't it? Even though that was only, 3 to 5 minutes or however long it was. Notice the difference between tension of even 10 minutes ago and how calm you feel right now. This is a skill that we can actually teach clients. And when you have clients who have, as the DSM-5 points out, physiological symptoms of post-traumatic stress disorder, progressive muscle relaxation, autogenic training is the warmth and heaviness, it's the sensorial. So there was no sun in the room, there was no difference in your body temperature, but when you said to yourself, my hands are warm and heavy, they became warm and heavy. And here's the deal, if I can create warmth and heaviness in my hands, can I create calm and serenity in my heart? Or a sense of safety and security, even when I hear a loud noise outside of the room? The answer is yes. Mm-hmm. And by teaching a client the processes of self-hypnosis, all hypnosis is self-hypnosis, in a formal process like this, we can really teach them another form of skill building that the research actually shows is truly useful. Now, you use a lot of hypnosis with your clients. We haven't discussed at all either direct or indirect suggestion, but metaphor is an important part of acceptance and commitment therapy. It's really an important part of the hypnosis work you do as well.
Yes, I use a lot of metaphors. So when somebody gives us a metaphor, they're giving us really their model of the world and how they see things. So there are multiple ways of working with metaphors. One of the ways that I work with, so you're either dealing with the client's metaphor or you're creating a metaphor for the client. If you're working with a client's metaphor, you can turn that metaphor into a number of different things. So if a client says that I'm at the end of my rope, they're giving you a metaphor. They feel literally as if they're at the end of the rope. So if you were to examine that metaphor and say, okay, well, how far down is it to the ground? Or, can you climb back up the rope? Or if they say I'm hitting a wall, well, how high is the wall?
Right.
How far or how wide is the wall? What is around the wall? Is there a ladder near? Can we create a ladder? All these different things, because a metaphor is really giving you their model.
And in a state of hypnosis, when I go through an induction like that and now examine the metaphors, this is the only thing they're focused on.
Right.
And it can really give them a vantage point that to this point they've never had before.
Right.
By the way, a lot of times people say to me, okay, maybe you guys are good storytellers, or maybe you're awesome at creating metaphors. I'm not awesome. There are a lot of useful tools for a therapist. In fact, I just realized, you can't see it over there because it's outside of the camera, but that's my bookshelf. Sitting on the top of my bookshelf is a great book titled Therapeutic Metaphors by David Gordon. And it's simply an encyclopedia of metaphors that a therapist might use to guide, teach, and instruct a client. And a state of hypnosis isn't a state of unconsciousness or being zapped or zonked. That's too much Hollywood. It's really just a state of accessing the creative and intuitive part of the mind so that we can utilize these, what are called indirect suggestions, metaphors, stories, parables. And I know you use a lot of storytelling with
I use a lot of storytelling. Also, I use concretization of a client's metaphor. So if I've had a client before tell me something like, I feel like I'm being hit, or it's just like being hit, they're having difficulties at work. It's just like being hit in the face with a baseball bat. And so I made that concrete.
Right.
Yes, I am sure that it's just like being hit in the face with a baseball bat. Because if you think of the psychological suffering that's going on, they are suffering at the level of being hit in the face with a baseball bat because of their story, right? And when I say, yes, it's just like being hit in the face with a baseball bat, then the client says, well, maybe it's like being hit in the face with a wiffle ball bat. And there's a relief that's given from them changing their metaphor. So concretization. And then when it comes, so those are the client's metaphors. When it comes to our metaphors, then yes, it's I use a lot of storytelling. I use a lot of metaphors. And the way I do that...
And if I come to see you and I have a PTSD, by the way, there was a lot of debate in the DSM-5. Should it be PTS or PTSD? And the DSM-5 continued to use the disorder rather than post-traumatic stress, dropping the disorder. That was really a bone of contention in the DSM-5 outside of the scope of this workshop again. But if I come to see you, you can tell me a story, and if you told me what to do, I would never accept it.
Right.
But if you tell me a story, back to Carl Rogers, that aha experience, well, I'm like the guy in the story. I too could take an alternative action.
Right. So one of the nice things about metaphors and stories are, one, they bypass a client's, or they bypass anybody's inherent rejection of new ideas, right? So if I tell you to do something or to think about something a certain way, you can say, no, that doesn't work.
Right.
If I tell a story, I mean, why do you think all religions use stories as teaching tools? They don't just tell you what to do. They tell stories. And, and that takes hold. That forms in our mind that we do want to be like somebody, or we don't want to be like somebody, or we want to be like that little groundhog that pokes his head out on to see, should I stay in my hole or should I come out now, right? It's all... the mind, this goes into some much deeper stuff that we don't have time for. But when we get into left hemispheric and right hemispheric concepts of the brain, the left hemisphere is where we find most of our cognitive errors and things like that. But the right hemisphere, which works more in pictures and more in the gestalt of things and whatnot, that's where we find our landscape, the internal models that we have that are built on pictures. So a lot of times a client has a story, a picture story in the right hemisphere of the brain. By talking in stories, we bypass the left side, the analytical side that can reject us, and we go straight into the right side of the brain that's more into the story, and we can reform the landscape of their model of the world.
Sure. And we've covered a lot of information in the last 3 hours. and we've introduced you to a lot of concepts. The cool thing about continuing education is that hopefully this has given you some ideas that are actually useful with your clients, and that you'll begin to implement these ideas, but even more importantly, recognize that these ideas are useful, and go on and get additional training in the areas which are most important to you. In-depth training, perhaps in EFT, or in clinical hypnosis, or acceptance and commitment therapy, or EMDR, or any of the other areas which have demonstrated efficacy with the clients that are on our caseload. Dave and I have enjoyed the time that we've spent with you in the past 2 webinars, and we look forward to seeing you at one of our upcoming webinars. Now, we are out of time, so below us is a link, and complete the link to complete the course evaluation. That'll automatically generate a CEU certificate. And you can always post any questions you might have for me or Dave on our forum at changeworkforum.com. I'm really glad that you participated in today's webinar. We will look forward to seeing you either at an upcoming professional ethics webinar, which we offer every month. Dave and I did a workshop, or are doing a webinar on taking a life, counseling people who have killed other people. There are webinars coming up covering the changes in the DSM-5, impulsivity and psychotherapy, and many other opportunities for you on our website at fastceus.com. We will look forward to seeing you soon.